About the third patient that walked in my clinic came in with breast edema, and she had a migraine in her chest. And I thought, we didn't talk about that. And so I had to call Gunther and say, Gunther, what is this? The other thing we learned early on in our training a long time ago is that lymphedema didn't hurt. Well, I think that's changed nowadays. But back then, that was one of the keys to understand whether this was really lymphedema or not, is that lymphedema wasn't painful. And the primary component of this patient's problem was pain. And when someone comes in and tells you they have a migraine in their chest, that's a pretty big. Yeah. And so I called up Gunther and I said, Gunther, what's going on here? I have a patient with a migraine in her chest. What do we do with that? And he says, oh, well, I said, she has breast edema. And I said, where's the product for the breast edema? And he says, well, we don't really have one. I said, well, what do you mean we don't have one of those? We're going to spend days and days talking about all this thing for arms and legs, and we don't have anything for a woman after she's had breast cancer? He said, well, I usually just tell them to go buy a bra that's too tight. Well, then I got mad. And I said, well, I think that's pretty not fair at this point in life, that you can have breast cancer and be told to go buy something that's a little too small.
The information provided on this podcast for educational purposes only and is no intent, nor should be used as a substitute for medical advice. Consult a licensed qualified medical physician for any issues concerning your health. If you would like to know different strategies to improve your quality of life during your cancer journey, this is the podcast for you. Welcome to Taking Charge of My Cancer podcast, where I'll be interviewing different healthcare professionals, cancer survivors, and I'll be teaching you different resources, tips, and solutions so you can get the best outcomes while dealing with a cancer. So welcome back to Taking Charge of My Cancer podcast. Today, we are joined by a clinician who is not only transforming lives in the clinic, but also reshaping what's possible for people living with lymphedema. She is a dedicated physical therapist specialized in lymphedema care, bringing both deep clinical expertise and genuine compassion to a condition that is often misunderstood and undertreated. But her impact doesn't stop there. Recognized a major gap in care, especially for those dealing with trunk lymphedema, she went beyond traditional therapy and became an innovator. She actually co-developed the Bellise Compresure Comfort Bra, a specialized garment designed to address chest and breast lymphedema with the functional properties of a short stretch compression. Her work was play a key role on bringing greater clinical attention and often overlooked on those type of situations. In this episode, we will explore her journey into lymphedema care, the challenge patients face every day, and how innovation can emerge directly from listening to those patients. Whether you are a healthcare professional, someone living with lymphedema, or simply interested in how one person can turn clinical insight into a meaningful change, this is a conversation that you don't want to miss. So let's get started. So I have Dr. Lesli Bell, and she is a highly respected clinician, educator, and innovator who has dedicated nearly 30 years to the field of lymphology. She's widely recognized as a pioneer in the management of breast cancer-related lymphedema and fibrosis, helping to advance both clinical practice and professional education worldwide. For more than 25 years, Dr. Bell has taught advanced therapeutic techniques nationally and internationally, significantly contributing to the training of lymphedema therapists and interdisciplinary healthcare teams. Dr. Bell has lectured extensively across the globe, sharing her expertise and helping to shape best practice in lymphatic and oncology rehabilitation. She's deeply committed to improve outcomes for individuals living with lymphedema, particularly those affected by breast cancer and related conditions. Over the past 30 years, she has served as both the state and national levels, including with Vermont chapter in the American Physical Therapy Association and the Academy of Oncology Physical Therapy. She earned her Bachelor's of Science in Physical Therapy back in 1884 and completed her doctorate of physical therapy at Regis University in 2013. 1988, she founded an outpatient orthopedic private practice in Burlington, Vermont, where she continues to incorporate lymphatic management as a central component of comprehensive patient care. She resides in Burlington, Vermont, when she enjoys the snow-filled winters and spending time on the lake in the summer. So thank you so much for being with me today. I really appreciate it.
Thank you for having me. It's a pleasure.
Absolutely. We were just talking about how much traveling you do teaching here and there. And I think I came across you. I have come across your work before. And of course, I've been coming across the Bellise Bra for so long, which I have no idea you were the co-creator of it until I hear you on a conference I went to in Orlando, just like in February or something. So I was like, oh my goodness, she is the woman behind this. So that's amazing. And that's how I really enjoy all your teaching and education about trunk lymphedema and breast fibrosis on that conference. So thank you for that. But what inspired you to create Bellise, and what clinical gap were you seeing in your patients with chest wall lymphedema?
So when I finished my training in 1997 with Gunther Close and Steve Norton when they were working under Dr. Lerner, quite a long time ago. And we spent a long time during that training understanding the role that compression plays in all of our treatment for this problem. And so we spent days and days and days wrapping legs and understanding garments and all of this. And so, I come back to the clinic and I realized that that this is an important component. And about the third patient that walked in my clinic came in with breast edema, and she had a migraine in her chest. And I thought, we didn't talk about that. And so I had to call Gunther and say, Gunther, what is this? What's this pain? The other thing we learned early on in our training a long time ago is that lymphedema didn't hurt. Well, I think that's changed nowadays. We understand that lymphedema can be kind of painful and uncomfortable and thick and full and heavy and all of the other descriptors that go along with that. But back then, that was one of the keys to understand whether this was really lymphedema or not, is that lymphedema wasn't painful. And the primary component of this patient's problem was pain. And when someone comes in and tells you they have a migraine in their chest, that's a big pain.
Yeah.
And so I called up Gunther and I said, Gunther, what's going on here? I have a patient with a migraine in her chest. What do we do with that? And he says, oh, well, I said, she has breast edema. And I said, where's the product for the breast edema? And he says, well, we don't really have one of those. I said, well, what do you mean we don't have one of those? So we're going to spend days and days talking about all this thing for arms and legs, and we don't have anything for a woman after she's had breast cancer? He said, well, I usually just tell them to go buy a bra that's too tight. Well, then I got mad. And I said, well, I think that's pretty not fair at this point in life, that you can have breast cancer and be told to go buy something that's a little too small. I mean, really, you're going to go shopping and try to find it at that point in time. I mean, it's a terrible time to try to, it's such an unprecise, request to a woman. And so I started thinking about it, and I was a design major before I was a physical therapist, and I didn't do well at design because I don't have a lot of artistic ability, but I think I have more of an engineering brain. So I kept thinking to myself, well, if there were certain components to this bra, and patients come in and they tell you what's wrong. Don't you experience that? They tell you what the problem is. If you listen hard enough, you can figure out how to fix them because you listened hard enough.
Yeah.
So, some of the components that they would talk about were they call it the dog ear or the wad or the kumquat or whatever they called it. There are all sorts of descriptors for that fluid, that swelling and fullness that they get in their armpit, and that part of the armpit that kind of spills over their bra. And another problem was, pain in the chest wall. And another problem was they couldn't tolerate how the band of their bra went circumferentially around their chest, and then their breasts were pendulous. And so there were all of these components that people were telling me about. So I happened to meet by chance the woman that invented the very first sports bra in the world, and it was called a jog bra. And I know that ages me just a little bit, because now you talk to younger people and they'll say, I didn't know there was never a time when we didn't have a sports bra. But she developed the very first sports bra that was called a jog bra back then. She actually lives in my town. And so through some circumstances, I ended up having lunch with her, and I showed her Polaroid pictures, because that's what we had back then. We didn't have cell phones. And I showed her Polaroid pictures of what breast edema looks like. And she was kind of shocked. And she said, well, I'm retired now. And I said, but if it had these components, so we take some of the components from a sports bra and then we add these things to it, create something that has a short stretch property to it by combining fabrics and Well, she went home for about 3 days, and then she called me and she said, okay. She says, I can't not do this.
Uh-huh.
So she had the ability and the context for how to produce something like this. And who do we call? Because in 1997, who did you call for stretchy kinds of fabrics that had the qualities that we were looking for? And so we started working together. She knew how to hire a bra designer. So I had the components and I knew what it needed to look like. And we hired somebody to make the pattern. And then we needed the fabric. And so I said, well, I don't know where you get this fabric. I'm up in Vermont and, excuse me, sewing has kind of declined in terms of, quilting is pretty popular, but making clothes isn't as popular as it used to be. So I said, where do we get these fabrics? And so she says, well, we'll just call DuPont. I said, you could just call DuPont. And so we flew down to DuPont and told them what we needed. And they just rolled in racks and racks of fabrics that I got to sit and feel and play with. And so in my mind, I was trying to mimic something that creates a short stretch property. Yep. Because as you know, and I know, when we are working with patients, that's the very best support system that we can provide for them. And if the edema is mild, then they might tolerate a circular knit or something with a little more stretch to it. But when I think of short stretch, I think of a container. We're creating a container for that edema, and that manages it better, and it's a lot more comfortable for the patient. But the other thing is it really has to fit. So, compression only works when it fits properly.
Yep.
So I wanted something that actually encapsulated the whole part of the breast, that went around the truck, that felt like a Speedo swimsuit. So that was sort of my inspiration for this product, is, how good it feels to get into a Speedo swimsuit that really fits well, where your breasts are not pendulous. They're in a neutral position, and you don't have that binding of the bra going around your trunk, and that the Speedo swimsuit would stay up whether your straps were on or not.
Yeah.
So it's not the straps that are creating that lift. So that might be a long answer, but that was my inspiration. And from there, we actually created the product. And so by 2001, we launched it at the NLN conference in Chicago.
That's awesome. And I know Juso, right, is the one who sold that, right?
Jobst.
Yeah.
Yeah. Jobst is now the exclusive supplier and vendor for the Bellise bra. Yeah.
Perfect. And then I will put that on the show notes. So if listeners wants to check it out, it's pretty great. So amazing. I love the story behind. So glad I asked you this. I didn't even know that. So that was amazing. How can you describe a patient experience that really pushed you to say, we need something better?
Well, I think I'd have to go back to the patient who had a migraine in her chest. Okay. So this particular patient was a teacher, and she had breast cancer, and and she was a 5th grade teacher. And so I think that 5th grade teachers, especially kids that are younger, they like to give their teachers hugs. And so she came in concerned and sad that her students were afraid to run up and give her a hug because they were afraid they would hurt her. And then that really got me angry. And I said, the thing we need the most after some sort of really serious medical situation is attention, love, touching, love, friendship, love. And here are these kids that want to come up and hug her because they love her and they want her to be well, and they were afraid to hurt her. Same thing with her husband. Her husband was afraid to give her hugs because he was afraid he would hurt her. So to have that sort of physical isolation because people are afraid to hurt you is really just not fair. So I think that was the patient that really turned my world around. And since then, I've had numerous patients, and it always comes down to the same thing. And when we were trying to think of a way to describe this, they wanted a tagline. The marketing company we worked with back in 2001 or 2, and they said, well, you need a tagline. And I said, well, I don't know what a tagline is, but I can tell you one thing: a hug should never hurt. And they went, that's it. So apparently I came up with it without even thinking about it, because truly a hug should never hurt.
Yep, that
was my inspiration.
So before Bellise, how were clinicians managing truncal or chest wall lymphedema, and when were the limitations?
So I think the limitations back then were, obviously trying to send some poor woman to a store and have her pick out something that's too small. What does too small mean? So that was a limitation. There were some burn garments out there, but that might be a little overkill, to have some of the burn time garments that could be custom made for patients. I think the other thing that they were trying to do is use like a long stretch bandage and just circularly wrap the trunk wall. And the problem with that is that it's hard to get the right pressure, number one. Number two, try to do that to yourself, which is even harder. So now you need the help of somebody else. And that would sometimes, when patients would have a seroma because of that, sometimes if they do surgery in the lateral quadrant and then they go take out lymph nodes in the axilla or the armpit, there's a communication actually between those two spaces. And so if you wrap the chest wall up pretty tightly, then you're going to push all the fluid right into the armpit, which is one of the complaints that patients would come to me with, is this fullness and thickness and hardness in the armpit. And I think that's one of the things that helped to make the chronic seromas in the armpit kind of bad. So we didn't really have a good answer. And as I started wandering around conferences and going to conferences, I mean, all kinds of different ones, nursing oncology conferences, physician radiation oncology conferences, and med trade I went to, and I went to fitter conferences. I spoke at those fitter conferences for probably close to 10 years because I developed a product for a problem that people didn't recognize, for a problem that doctors didn't acknowledge when the patients would talk to them about, a problem that insurance companies didn't know they needed to cover for a patient, and the fitters didn't know how to fit for it or even evaluate it. And so that's a pretty big, I think, had I thought that out really clearly, I probably wouldn't have taken it on. That's an awful big problem to try to solve between doctors referring for it, patients recognizing it, fitters fitting for it, and insurance companies covering it. That's a big problem.
It is, but you know what is the part that you're thinking, we're looking back on 2020, 2011, 2001, now,
26 years ago, 25 years ago.
Exactly. And now, guess what a lot of patients get after breast surgery? That ACE wrap around their chest, right? When they take the drains out, that's what they do. They just wrap around for 24, 72 hours to try to prevent seromas, So still the same ACE wrap around it for a different reason, but how much of this is actually creating issues, right?
Well, that's a good question. And I think that I think the 24 to 72 hours doesn't bother me too much, but then we go and we radiate these patients. So, I mean, the seromas remain a huge problem. We can't even seroma is not even really a side effect anymore. It's an expected complication because they're so common. I mean, probably more than half, I think it's like 60, don't quote me on this number, but it's 60+% of patients get seromas. And then, a good portion of those will resolve spontaneously, but then there's the ones that you and I have to try to treat that are really chronic.
What are your thoughts about what are the seromas coming from?
Well, I mean, I think they're probably coming from, obviously they cut those lymphatics and the lymphatics drain and it becomes a negative pressure and it just kind of pulls it into that space. But I also think that if we think about, if we had an amputation of some sort of limb, an arm or a leg or something, we don't want a seroma in those because then the prosthesis isn't going to fit right. So what do the doctors do? Well, they leave that compression on for quite a bit longer than 48 hours.
Okay.
So I think that if these patients had support on from the time they left surgery, because that's when they would put it on an amputation, they wouldn't wait a day or two to do that. But I think in the chest wall, when they're really going after the lymphatics versus but when they do an amputation, it's a much bigger surgery. But when they're really going after the lymphatics and they're leaving the rest of that anatomical tissue present, then it turns into a bigger seroma. But I've often wondered, I mean, one of the applications that I always thought would be very handy is to put a patient in a product or a bra like this one and have them wear it for the first 6 weeks, 8 weeks, because that's how long it takes healing to take place. And those lymphatics, we understand now that lymphatics can actually heal a little bit better. We used to think that once they were cut, that was it, but I don't think that's the case. They can regenerate. But like any other connective tissue, it's about 6 or 8 weeks. And so if we could have support on that tissue where the internal pressure of that seroma draining in is supported by external pressure, then that might be an option.
I don't recall, is your Bellise, do they have, how sometimes a lot of these patients come out of surgery with drains? Do they have a space for the drain to come out so they can use it?
Well, you don't actually need a space for the drain to come out because usually the drain is placed flat to the trunk. It's not coming out at a 90-degree angle. It's kind of coming up like this. So that's not a problem. And actually, because my intention at the beginning was that patients could be put in this at surgery and come out of it, we actually have a drain pouch, and we went to a lot of work create the option to use this post-operatively.
Okay.
The resistance that we've had in terms of using it post-operatively is that it has to be fit. So unlike some products that are out that are small, medium, large, extra large, that's only 4 sizes that they have to keep in the OR. We have sizes that go from 30 to 50, and then we have 3 cup sizes. So if you add that up, that's a lot of bra sizes. But on the other hand, as a woman who wears a bra for my whole life, I wouldn't go, especially, I'm not a B, I'm bigger than that nowadays. And I wouldn't go buy a bra, a small, medium, large bra. I don't find them comfortable at all, because with pendulous breasts, you've got to have enough support of that fabric to actually lift the breast tissue up and hold it in place. Otherwise, these bras just tend to roll up underneath the breast crease.
Okay, that's great information. I may bring this up to our breast surgeons and see we can start to do a little trial and say, how can we get this bras from the beginning and see if that maybe prevents some of these seromas that is happening. So that's a very good point.
The other thing that would help seromas is, so I have some kind of interesting people that live in Burlington, Vermont, which is not a big place. We're kind of a little place. But the physician, Dr. David Craig, who actually adapted sentinel node biopsy from melanoma to breast cancer and did the very first sentinel node biopsy testing on women with breast cancer, is also from Burlington, Vermont, and he's my friend. So I sat next to him at a wedding one day, believe it or not, and we started talking about our respective inventions. Well, he wins, okay, I totally get that. But he looked at me and he said, I can't believe you invented the bra. He says, because my nurses and I tried to make that and we couldn't figure out how to do it. He was very interested in using it for his patients after surgery. And he did several, but at that point he was really involved in research. So we didn't ever get to really do a trial. Okay. But he actually wanted me to talk to, the Department of Defense is at one point several years ago was a large contributor to breast cancer research. So I got to go to a conference with him and sit with him at a table with all these people from the Department of Defense. And his thought back then was that we could even get the drains out sooner or not need drains if we applied the appropriate amount of compression to these patients right after they had surgeries. Wow. So that was his intention. Now, but here's the second part. If you're going to do a sentinel node biopsy or a full axillary dissection, you need pressure up into the armpit. So he and I worked with Jovipac at that point in time, and we created this great pad that comes up the side of the chest wall and goes into the armpit like this. And it also covers the whole front and the back of the armpit. And when you put your arm down, it kind of gives you that upward pressure into your armpit. And it's something that if patients are sleeping in it, that their arm can move around below 90 degrees and it maintains support up into the axilla. And so we created this axillary pad, and he loved that thing. So, but again, a lot of people don't know that that was the beginning of that kind of a support system. So having something that goes up into the armpit to keep that seroma from coming, and if there's a communication with the area that the tumor was removed from, having support on that, it makes a really big difference. The pad that we created also kind of comes around the whole side of the chest wall, because most of the breast cancer tumors are in the lateral quadrants.
Yeah, that's a very good idea. I don't think I've been.
So if they woke up in that bra with that pad, now they've got compressive support, comfortable support that they can wear maybe 23 plus hours a day for the first at least 10 days, because that's the time it takes just to take 2 things and connect them together. Okay. So, and then those patients should probably be wearing support for, up to a year, because then they're going to get radiated and there's a lot of interruption that's going to continue to happen. So that was my intention, but trying to change surgeons' perspectives, maybe on what they might add after surgery is a big challenge. So if you want to talk to your surgeons, I'll fly down and talk to them too.
Awesome. I will talk to them. I will do that for sure. So what were the biggest challenge in creating a garment, especially for chest wall lymphedema? And again, you kind of already gave me this story, but as you were creating it from the PT, CLT, and a certified therapist, I know you were like a brilliant mind behind okay, how can I support these lymphatics? But at that point, we didn't know a lot about lymphedema in the trunk, right? So
that's true. We weren't even talking about it. It wasn't even being taught.
Exactly.
So I think probably the biggest thing is that from my design background, I know that if there is volume present, that's where darts come from. I mean, to kind of go into clothing, clothing, if you want your shirt to fit nicely and you have a bust line that needs to be accommodated for, you have to put a dart in it. Otherwise, the fabric won't fall over that space. And with lymphatics, we know that if there's not compression present on all sides, then you're not going to get compression in the area that it's not touching. So that's when I came up with the princess seam. So a princess seam is a seam that goes down the center, and it's a way to like add or subtract fabric to accommodate a mound or a bump. Okay. And so so our product, instead of being a stretchy thing that just sort of like stretches over it, because then obviously the pressure is inconsistent, right? And also they have bras that have what we call a punch out, meaning that they put it molded and they heat mold it so that it creates a space or accommodation, but that's not going to have the same compressive forces. So by adding a princess seam in, that's adding the smooth, equal compression from all the same direction, from all the directions going over the whole breast mound that we're trying to compress. And it also does it without squeezing too hard. So when I talk to my patients, I talk a lot about having what I call squeezy compression or container compression. And short stretch, your short stretch is more of a container compression. Squeezy compression is more of a lycra kind of compression, which some patients tolerate and some patients don't. But if I'm trying to lift a pendulous breast that's hanging down, the person's bigger than a B, minus size, the only way that breast is going to drain is if it's lifted up and the nipples are going forward. So if the nipples are pendulous or hanging down, there's no muscle in that breast tissue. It's not going to drain properly. So we had to come up with a short stretch fabric that accommodated all sides of a breast tissue that didn't squeeze but applied a short stretch force. And then I didn't want it to go all the way around and tourniquet the body. So I stopped that inner bra at the side seams. So then on the back, it's 2 layers of a very smooth, again, back to the Speedo swimsuit. So you get this nice compression in the front, stops at the side seams, and then it's not continuous through the back where we need things to drain properly. So it gives you what I call the tube top effect.
I like that. Now we go into more the practicality of some of the audience or our physical therapists out there, or even patients who are going to PT. What will be some good strategies that you can use besides? So we have the compression, and that's a great part of it. But what other techniques have you been seeing successful in treating breast swelling or trunk swelling?
Oh, I have a whole bunch. I mean, certainly we also have to treat the physiology of this problem. And that's, we get the radiation and the scarring is a big issue. So obviously manual techniques are helpful. Stretching of scars are helpful. But in some of the more persistent ones, I use cold laser. I use a laser that uses a wavelength of 904 superpulsed, and that changes the inflammatory situation in the tissue dramatically and makes it much more comfortable. Most recently, I've been using something called focused extracorporeal acoustic compression, or better known as focused shockwave, and that is tremendous on breasts, and I've seen immediate deflation in some of these very chronic swollen breasts. So I think that when the tissue gets hard is when we have a hard time controlling it with compression. So our goals as lymphedema therapists is really to soften tissue and create suppleness, and that suppleness is going to help promote lymphangio pulsations. It's going to help with the movement of that lymph fluid through those vessels, and a hard tissue is not going to allow that. So anyways, there are some modalities, and manual lymph drainage is one of them that helps, because certainly when we get the fluid out, it decreases the chronic inflammatory situation in the tissue. But then there are several patients, or many patients, that's not all they need. And these modalities that change physiology are really valuable.
Okay, that's very good tips. What role does it play alongside exercise? You kind of already talked about manual lymphatic drainage, but how about exercise?
Well, exercise is a really big deal, because exercise changes posture. Exercise requires good breathing technique, and exercise improves range of motion. So we never get away with not doing that. And these patients come to us in all different shapes and sizes with all different comorbidities and backgrounds. And so, exercise helps with pumping, but the one thing we have to remember, it helps with pumping in the arms and the legs, but the breast has no pump. There is no muscle in the breast. So that's one of the reasons that sometimes just this squeezy compression doesn't feel so good for patients, because there's no pumping happening in the breast. So that's why positioning of the breast is really important. And we position it in a way that it allows it to circumferentially drain. And that makes a big difference. So having the support and the inability of it to swell into it versus trying to squeeze it out. Does that make sense?
Yeah, makes all the sense in the world. Is any particular exercises that you will focus on? Like, just kind of anything that involve the pec that create that a little bit of that pump effect?
I like all kinds of, I think passive range of motion and dumbbell exercises are nice. Band exercises aren't bad. Sometimes band exercises get stiffer the further out you go. So sometimes weight exercises are a little more consistent for patients. Probably my biggest pet peeve, if I have one, is that I hate wall walking up the wall. And I hate wall walking because it promotes upper trap activation, and I want the inferior scapular stabilizers to come into play. So I do one where I put the wrist on the wall and push a washcloth up the wall, and then you push on the way down, and then all of a sudden you start to promote good scapular mechanics. So that's probably my biggest pet peeve.
Okay, very good. How important is early intervention when it comes to truncal lymphedema?
Well, I think it's really important, and I wish that we had the opportunity to be very preventative about it. And just like, Dr. Nicole Stout, her studies came out and said, gee, when a patient thinks they have a full arm and we put a sleeve on them and they wear it all day for, I think it was 4.2 weeks or something like that, they return to baseline. And at 1 year, they did not have measurable lymphedema. And I think that we could treat the trunk that way as well. The difference is that the arm is not being accosted during breast cancer treatment. It's the breast. It's a breast with no muscle in it. So I think that why would we not take this, lump of fatty and glandular tissue and support it to begin with, because it doesn't have pump opportunities. Why would we put it in a pendulous state? There's lots of different products out there, but anybody who's a B+ or more, find a bra that can lift up the weight of those breasts and hold them in the center without rolling up underneath the breast crease is challenging. So I think, there's different products for different problems, but I think anybody bigger than a sort of a B- breast size, anybody that's pendulous would probably do better with something with short stretch qualities.
And then what do you wish more clinicians understood about chest wall lymphedema?
Probably that, just what I just said, that we have to take into account that patient's anatomy. Okay. And not just say that, just like all garments aren't the same, over-the-counter garments are not the same as Amazon garments, which aren't the same as flat knit, custom garments. And the one thing that I wanted the Bellise to be able to do was be customizable. And so that, because we have a zipper up the front and the hooks down the back, we can actually flare the bottom or flare the top by moving the hooks in a diagonal direction. So that's a customizable option. We can also undo the bottom two hooks that flare the lower part so it doesn't roll. It might flip on patients in certain positions, but then, we're talking about posture. If I do a posterior pelvic tilt and I of course I'm going to get shorter in the front. So coming up with some kind of positioning for if they're in a sitting job that gives them some lumbar support so they can sit up straighter would probably be helpful. But I wish that clinicians would think about the anatomy of what they're trying to change and which of the products on the market are going to help that particular patient with their anatomy challenges based on lymphatic congestion, and not just assume that they're just not all the same.
Correct.
Yes, and
go ahead.
And compression only works when it fits.
Yep, that's true. And I think that one thing as well that sometimes I come across patients who has been in other clinicians is, unfortunately, you can have a CLT initial after your name, but the clinical eyes and looking at a whole quadrant and a whole person versus just an arm, right? So I have seen so many patients who go see a CLT lymphedema specialist and they only look at the arm. That's it.
Right.
It's only
not just the arm.
It is, the arm is not connected to the chest. The arm is not connected to the scapula. The arm is not connected to the trunk. They never look at the breast. So many times these patients actually develop swelling from the beginning, but the therapists, they only just doing the whole CDT to the arm and totally forget that it's attached to something else. So it's just hard because sometimes I don't remember, and I don't know if you have that. I became a certified lymphedema therapist to Norton many years ago, but I don't remember they mentioning at all that back then. And I think I always have taken in consideration, because my manual therapy background, where you're looking at the whole picture and the whole quadrant, which where I was start kind of looking into this and start working on ribs and start working in all these tissues and try to restore anatomy to have better outcomes in these lymphedema patients. But you're right. I don't think I ever was told at all like that, right? Like the other thing as well, right? Like we were told about these anastomosis that we know right now that they don't really work that way anymore. So it's super fascinating how kind of like shebang of like I'm sure you were like in Las Vegas on power of the Power Lymphatic Symposium, and I'm sure you listened to one of my favorite docs in the world, Dr. Singhal, talking about the changes and amazing changes that are happening in the anatomy of the lymphatic system, which is so great that we are closer and closer to understand more and more what we're dealing with so we can actually make a difference. So it's very exciting.
Yeah. And, and our responsibility as therapists is when we know better, we have to do better.
Mm-hmm.
And I wish that more therapists had the opportunity to come to some of this advanced training, because I think that, a lot of the CLTs that are out there, they just don't know better because they haven't had the opportunity to go to some of these conferences and start to learn the new stuff that's going out, and they're stuck in what they learned initially. And it's an evolving science.
Exactly. Do you see future innovation in compression technology for oncology patients?
Do I see? Say that again.
Do you see future innovation?
Future innovations. Oh,
Compression technology for oncology patients?
well, I mean, sure, surgical options can change, and that would be nice because, we're treating the changes that happen in anatomy based on surgery and radiation. So that would be nice. And reverse mapping would be a lovely thing if that was actually something that was optional for patients so that they didn't even take the lymph nodes. I don't think it's going to fix the breast problem, though, because the breast is where the tumor is. So they're always going to be even if they do reverse mapping, they're always going to be having to take out lymph nodes unless they come up with something else to stage that cancer and decide how they're going to treat it. I think in terms of the future technology, I don't know about technology, but I think techniques would be great. I think, again, back to, instead of now sort of the interest is to do these lymph node transfers, at the time of surgery to prevent lymphedema, and maybe reverse mapping. If we didn't take those nodes to begin with, that might be a way to reduce arm lymphedema. But the chest lymphedema is the bigger problem. And why don't we just go back to the basics of supporting the tissues that we just interrupted? See what would happen if we put these patients in, a quality compression product that was comfortable enough for them to actually wear for day and night, and wear that for 6 weeks, and let's see what happens.
That's a very great advice. What continues to motivate you in your work with oncology and lymphedema patients?
I think the thing that motivates me the most is the not fair. This is just not fair for them. The side effects that come to these patients from this treatment is just not fair. The fact that, any cancer is not fair. Chronic illness isn't fair. And I think that my dad was an engineer, so I'm always looking for a better mousetrap. I always want to find a solution, and I try to be very observant, and I'm not afraid to try things. I think that's another thing, is that I'm not afraid to try something new. If the upside is high and the downside is low, why would we not try that? I mean, that's sort of the wonder of being a therapist or a physical therapist, for sure, is that the upside is phenomenal and the downside is, well, we didn't cut it off, so there's good news. So we have this ability to try a lot of things and put different treatments together and come up with a unique plan for each one of those patients. And I think that's what I would like therapists to think about is, how can they look at this patient and understand the unique qualities that they have presenting, and what can we do to change those? I don't know. I'm always looking for a better way to manage this and to improve quality of life for, my friends and all the people that unfortunately get this problem. I want it to go away.
Absolutely. And I'm totally there with you. I think that it is fascinating seeing how things are changing, at least on the breast cancer world, right? Like used to be like everything was taken out, and now we're like, like even having a trial now that is certain patients with certain breast cancer, they don't even need lymph nodes. So it is amazing how we understanding that the more is not better necessarily, but this actually can prevent more complications and all these cancer treatments. So we got to understand that, each patient can have exactly the same diagnosis, but they're so individualized. They're just their own little person that we got to be really customize everything that we do for them based on each that specific person and what they do for living and their lymphatics, their anatomy. So I think that the more we see patients that way, the better outcomes we're going to see.
I agree.
Yes. So this has been a wonderful conversation. You tell me already so much, and I really, really enjoy it. Thank you so much for being part of the show.
Oh, thank you so much for having me. It's my pleasure.
Okay. You have a great afternoon in Vermont.
And I shall. Hopefully it'll get more sunny again.
Okay, perfect. You take care, Lesli. Bye-bye.
Take care. Bye-bye.
Thank you so much for listening to the latest episode of Taking Charge of My Cancer podcast. If you have not already, feel free to share this with more people so they can benefit from this information. If you would like to connect with me, see the information on the podcast description. See you later.